Hello, Mate to Thrive Nation. Very, very important episode. It's all about hormonal health. It's with an absolute health hero, a health legend that I've been following. We're going to put some real links to his health podcast called the Gillett Health Podcast. He's a father, he's a husband, and he is board certified in family medicine and obesity. It's a privilege to have Dr. Kyle Gillett on the show.
My pleasure. You are very kind.
Yeah, well, you're an incredible inspiration to many, many. But I want to start about talking about hormonal health. I know you've got so much information and try and direct you by giving you a few filters, Kyle. And one of the filters is an avatar that I'm seeing more and more. We do a lot of corporate work, executives, SME work, and they come in from the age of about 30 to about 55, and they're really struggling with their hormones. They're feeling tired, exhausted. They speak of burnout. And then we do the whole gambit of audits. But I do want you to start with what type of testing you do, the full blood audit. Do you do amino acid testing, essential fatty acid testing? Do you do heavy metal testing? I've been doing functional medicine for 17 years, been learning a hell of a lot. But I want you to take us through a little bit of a process on auditing, at the same time talking about behavior change, then talking about nutrition, and then lastly talking about supplements. So I know there's a lot there, but let's start with a female and a male, where you start your assessment process.
Yeah, the assessment is for hormonal health is started very similarly to other health topics with history and physical. Now, there are baseline labs that pretty much everybody needs, both baseline once in a lifetime sort of labs or genetic tests, and also baseline serum labs to monitor your hormonal health progression as you age. But that's why I named it individualized medicine. That's what I consider myself to practice. And at some point, I would like to have an individualized medicine fellowship that physicians and nurse practitioners and functional health providers can go through the curriculum, just like people get certified in obesity medicine or any other specialty. So to directly answer the question, you need to start with testing your testosterone, your estrogen. Estradiol is your main estrogen. Testosterone is your main androgen. And your progestogen pool, which is basically progesterone, pregnenolone, in addition to your more normal labs like insulin, which is taken fasting, hemoglobin A1C, a CBC, a CMP, a lipid panel, an ApoB, and a lipoprotein little a. Okay. So those are your really high yield blood tests that you should get not necessarily before everything else, but either at the same time as you get your other baseline labs or before.
And DHEA and cortisol, I know that you've spoken about DHEA. How important is that? Because we, make these diagnoses of adrenal fatigue and burnout based on the ratios, DHEA cortisol ratio test. What about those?
Yeah, very important. Cortisol is interesting. I do recommend starting with the serum cortisol. Cortisol is one of the tests to where testing metabolized cortisol can be very reasonable. Androgens and estrogens share a binding globulin called SHBG. That's basically the taxi that takes around the hormones. They're not really used when they're in the taxi, but they're protected from metabolism. So they'll look lower in the saliva or the urine. And then progestogens like progesterone share a binding globulin with glucocorticoids. Cortisol is a glucocorticoid. Okay. However, the reason, as you mentioned, that DHEA and cortisol are related is the release of both is stimulated in part due to ACTH, which is a hormone that your brain sends to your adrenal gland, which is a small gland above the kidneys, which produces both cortisol, one of your main glucocorticoids, in addition to cortisone and others, and also DHEA, which I call the pawn on the chessboard of hormones, which you do see decrease over time. And there is a huge variation in DHEA production. Some individuals hyperproduce NCCAH. It would be very normal to see a level over 1,000. And some individuals, even in their 20s, when you expect a level several hundred, already have a level under 100. And that's what some people call adrenal fatigue. That's what the medical community calls adrenopause.
Okay, brilliant. And then what about looking at DHT? I think it's dihydrotestosterone. How important is that as a marker? And its impact, obviously, is significant on hair loss and just testicular function and strength and energy and endurance and those things.
Yeah, so DHT is dihydrotestosterone. It is basically testosterone that is 5-alpha reduced. And as far as we know, my colleague James, some people might know James O'Hara, nurse practitioner, but we joke about the DHT receptor. That we know of right now, there is no DHT receptor. So DHT and testosterone share a receptor called the androgen receptor, and it's on the X chromosome. So females have one, males that are XY have one, and then females have two. Most females have two. Individuals with Turner syndrome actually do have one.
Okay.
So it's really interesting to see studies. There's a lot of studies on synthetic androgens like oxandrolone, which is Anavar, with on females with Turner syndrome, XO for bone growth, et cetera. And obviously that does not aromatize, but not to rabbit trail too much. Testing DHT, and yes, Anavar or oxandrolone is a DHT derivative, is particularly important for individuals that are less sensitive to androgens. So the analogy I make is a door. That's your receptor, because the level that's floating in the blood, that doesn't really matter. That's not actually having the action. That's just a level that's in the street or in the taxi, unless you're inside the cell, which in the analogy, you're inside the building in the city, that's your body. You're not making the exchange or the order. So the order is when the gene's actually transcribed and activated. And before that happens, the receptor has to be bound. It's modulated by several things like heat shock proteins. So yes, in some cases, cold therapy or sauna can help modulate these heat shock proteins. And things like L-carnitine and even tadalafil can help with the density of the androgen receptor. But that analogy is a door. So you go from the street, and in order to get it into the building or activate that cell, do the action of the androgen, whether it's DHEA, a very weak androgen, or testosterone, a medium strength androgen, or DHT, an extremely strong androgen. Think of World's Strongest Man, like Thor, or Brian Shaw, or whoever. Iron Baby, I think, is one from Africa. But they burst down the door easily, even if your door is a metal core. Now, the heaviness of the door, that's genetically determined by something called the CAG repeats. So basically, some people are just born with a door that opens very easily, and they tend to get prostate cancer more often. They tend to feel fine with lower DHT or even no DHT, actually. And they also tend to have things like progression of male pattern baldness and also less breast cancer.
Okay.
But and those people have a very light door. If you're not very sensitive to androgens, or you have relative androgen insensitivity, in an extreme case, when that protein does not function at all, you actually have something called AIS, androgen insensitivity syndrome. You have an X and a Y chromosome, very high levels of testosterone, but you appear female, and because it's been present even from the time that you're in the uterus and as a newborn, you actually develop female external genitalia and are considered female. Now, obviously, that's not very common, but every individual has a different amount of CAG repeats, and every individual just genetically has a different sensitivity. So in cases where that door is genetically very heavy, DHT becomes very important for quality of life.
Sure. So that's in terms of looking at bloods and that. Is there anything else that we need to look at before we answer the question, why is testosterone, all these androgens, so important? You know, I've been doing it for so long now, and I think 50% of, the baseline has been lost in the new generation to testosterone, and that's important for females and males. Females having more testosterone actually than estrogen by volume. So why isn't it so important? And are there any other blood tests that you do or labs?
So it's very important for the health span, both for health purposes. And the main reason why that is important is, especially in males, and there's individuals that are XX and XY actually have a pretty significant difference in their response to exogenous testosterone. We know this from what's called insulin clamp studies. It's the gold standard for determining insulin sensitivity. That's how we know NMN and NR are insulin sensitizers. But in individuals that are XY, it's an insulin sensitizer, so it prevents prediabetes and diabetes. Partly, obviously, most people have that effect, including females, if they're able to maintain a higher lean body mass and metabolism. But independent of that effect at the cellular level, it is also the case in males.
Okay.
So with our what the CDC considers an epidemic of metabolic syndrome and obesity, it's of particular importance to prevent that. I like to say the number one thing that you can do for your health, even outside of quality of life, is using whatever means are reasonable to prevent getting a diagnosis of diabetes. Okay. And testosterone is whether it's exogenous or endogenous optimization of your testosterone levels, that can make a huge difference. And then obviously for quality of life purposes, the clinical literature is very clear. Having low levels of testosterone, whether you're male or female, significantly decreases your quality of life.
Brilliant. So put it into sort of just cognitive abilities. Does it give you a sharper mind, more focus, ability to function? So we've got our avatar. Let's go back to the avatar, 35 years old, kids, career, feeling very, very stressed, feeling tired, exhausted, burnt out, maybe sleep disruptions. How important is measuring their testosterone in male and females at that sort of, lifestyle?
Yeah, it should be measured. And even in cases of depression, both thyroid hormones and androgens and estrogens should be measured. And if it's a female, at the appropriate time of the cycle, which is usually when they're having the most symptoms. So for most females, that's day 21 to 25, but not all. Sometimes it's follicular phase, sometimes it's even ovulatory phase. So extremely important to measure. With that avatar, you're also, of course, and nothing is done within a vacuum. Testosterone optimization, whether it's TRT or naturally optimizing your testosterone, is never done in a vacuum with medications. You always implement lifestyle interventions. Medications and supplements are just tools to help those interventions help.
Brilliant. So let's talk about those behavior changes. What are the most important things in males and females to optimize testosterone before we get into nutrition and supplementation and drugs?
Very similar to any other health condition. Diet and exercise are the first two for almost everything. And then I call the others the pillars of health. I used alliteration to name them. So you have sleep, as you mentioned, stress, both making your stress feel good, not necessarily eliminating all stress. You have sunlight, that's just getting outdoors, heat and cold exposure, etc. You have social health, which we know of as of particular importance given the last few years. And spiritual health, that's just where you are on your metaphysical goals, Maslow's hierarchy of needs.
Okay, so let's go and just dive down a little bit. Sunlight, how much sunlight do you need? I mean, I know you've been on Andrew Huberman's podcast. We'll put links to that incredible podcast you've done with him. Is it the 10 minutes on a bright sunny day? Is it getting sort of a lot on the body every single day? Is it measuring your vitamin D to make sure you're at 60 mgs per ml? Sort of what is your recommendation? What are your sort of biomarkers that you would look at?
All of the above. And if you do have a low vitamin D, yes, replacement is very reasonable, but also thinking about why you have that low vitamin D. Is it diet related? Is it exposure related? Are you getting very low sunlight? Sometimes it's inevitable too. Sometimes you're just doing night shifts all the time, for example, during residency or whatnot. But you do want to do all the above. And the sunlight pillar, part of that is it's a microcosm. The low vitamin D levels, the low amount of sun exposure that we have, that we live in artificial environments compared to our ancestors. Our bodies adapt well when it comes to having a well-regulated nervous system when we are not in an artificial indoor environment at, I think it would be 25 degrees Celsius, 20 degrees Celsius, yeah. 20 to 25 degrees Celsius, I think would be about 70 to 80 degrees Fahrenheit. Sorry if that conversion is way off.
No problem.
But, yeah. And then having all artificial light, having blue light the last hour of the day is certainly not helpful, or full spectrum light. And then not having the low solar angle light very early in the day or even very late in the day as well.
Yeah. So sunlight, lack of sunlight affects your testosterone. And what about sunlight on the testicles? And, we'll go into sort of the biohacks of red light therapy and infrared, but is that true? Exposing your testicles to the sun will improve testosterone?
When it comes to improving or boosting testosterone, one of the concepts to keep in mind, whether it's infrared light or sunlight to the scrotum or any other intervention, is you're not really boosting testosterone. I saw a quote. There was some andrologist, I think he was urology trained, but he talks a lot about hormones, and he says there's no supplement or intervention that can boost your testosterone significantly, because otherwise it would be banned. And a lot of that is just semantics. And what I mean by that is it's basically the way that he phrased that. It's technically true. When you're trying to improve your testosterone, instead of doing one thing that's going to like overload everything else that's holding it back, that's not going to have a significant effect. But if you find what the rate limiting step is, then other things can certainly help. So in cases where you've already optimized your testosterone, let's say your total is 1,000 and your free is 25, then extra sunlight and infrared therapy to the scrotum is probably not going to make a huge difference. But in case where you've had a lot of oxidative stress and you're already keeping your testes cool around 90 to 92 degrees Fahrenheit, whatever that is in Celsius, maybe 34, maybe a bit less than 34, maybe 30. But anyway, when you've already done those things, especially if you have iron buildup, if mitochondrial dysfunction is theoretically the rate limiting step of steroidogenesis in the testicles, then theoretically red light therapy and full spectrum light can help. Especially, I think it's 570 nanometers is a specific wavelength of red light that helps the mitochondria function. And we know that's true in the retina, so it certainly helps retinal mitochondria. It's just unknown whether or not it's also true of basically testicular mitochondria. Maybe.
Yes. Sounds like a good study to do. But let's go into nutrition. What are the big sort of things that people have to do nutrition-wise to optimize their testosterone?
If individuals have low SHBG, especially if they're insulin resistant, then decreasing calories and decreasing carbohydrates are the main two things to do. Now, everybody is in a different situation, and even just genetically, depending on what genes you have been dealt, what hand you've been dealt genetically. Some people tolerate carbs better, some people tolerate fats better. So finding a diet that is good for you, that you can also adhere to for a long period of time.
Okay. Brilliant.
It's
Sustainability.
probably, yeah, you don't want to develop orthorexia or unhealthy eating habits by finding a diet that is theoretically perfect for you, but that you hate.
Yeah, brilliant. And then moving on to exercise, are there specific sort of, is it weightlifting, heavy weights? Is it functional training? What does cardio do? What optimizes or what decreases affects testosterone levels?
Yeah. The first thing to tick the box of is finding a movement pastime that lasts a lifetime, because any movement that's going to get you 80% of the return with 20% of the input. Even if you do full body interval training, supersets of resistance training, where your heart rate's in zone 2, if you do that 2 days a week, then there's 80% of your benefit right there. It's an unbelievably high return on a low amount of time investment. Now, past that, you want to get at least 90 to 120 minutes, if not more, of zone 2 training. That's going to help your REM sleep. That's going to help maintain the health of your mitochondria. The analogy I make for that is elite athletes have similar mitochondrial function to young children. So if you've seen a toddler bouncing off the walls with energy, yes, they do have significantly better mitochondrial function than most adults. So more zone 2, and then like downstream to that, better REM sleep is really going to help with the function of that, way more than creatine and NMN and plasmalogens and epitalon and MOTS-C and other things that can help mitochondria. But
sure.
you check your box before you use a shovel.
What's fascinating is you're always speaking about sustainable transformation. What diet are you going to have that's going to be long-term, that's nutrient dense? What exercise are you going to do that's going to be long-term? How important, and from a consistency perspective, are these nutritional changes and the exercise changes with regards to hormonal health and testosterone health?
Yeah, consistency is extremely important. Think about muscle as a hormonal organ, and the changes in your lean body mass, both bone mineral density, but especially muscle mass, that's indicative of what we call paracrine and autocrine hormones, but also endocrine hormones. Paracrine and autocrine is from the same cell or from nearby cells or organ systems. And that takes a long time of consistency to notice a sustainable change. You can be extremely consistent for 2 months before, with resistance training, before noticing an obvious change in your body composition. And the same is true of the health of your endocrine hormones, because just like your muscle is a hormone, like I don't want to say hormone factory, but it essentially is a hormone factory for paracrine and autocrine hormones. The gonads and the adrenals are also hormone factories where that consistent change will really stack up 2 to 3 months. That's why in cases of natural optimization, usually I have people wait at least 2 months, if not more, before rechecking labs.
Okay. And for the male and female avatar, once their testosterone goes on the lower side, what numbers are you looking at with regards to that optimal level in male and females? Because I think that's an important, because we've got these huge ranges that are, different to normal ranges to optimal. And then secondly, what are the symptoms in females that they come up with if they're on the lower spectrum?
Yeah, I'll address females first because it's they're a bit more technically complicated, because testosterone does vary throughout the menstrual cycle. You can Google a chart, picture's worth 1,000 words, right? And you can see the little hump during ovulation. Yes, your LH spike is going to also help with more testosterone secretion from the ovaries, what's called theca cells. But there is a huge variation, much wider variation in women, whether or not you have more testosterone that is synthesized in the ovary or synthesized in the adrenal. There's a lot of ways to tell definitively what comes from what, but just checking a DHEA sulfate is my favorite way to tell. If it's higher, then it's more likely adrenal dominant. If it's lower, then it's more likely theca dominant. So as I mentioned, females have different levels of androgen sensitivity as well. If you have PCOS, that's one of the conditions that's known as androgen dominant. Then if you have hirsutism or virilization, hirsutism is hair growth in unwanted areas, for example, beard hair or male pattern baldness in a female. Or if you have deepening of the voice or polycystic ovaries, there's a lot of other symptoms. Epigenetics is often at play here because there's 2 different androgen receptors in the hair follicle, in the ovary, in the skin. The more sensitive androgen receptor is almost always expressed. It's called mosaicism. If people are familiar with mosaicism, basically it's like a light switch, and the gene that is hypersensitive to androgens is almost always turned on in those tissues and at an even or more normal balance in other tissues. So you always look at, well, what can change those epigenetic expressions? Obviously, lifestyle does slowly, but you can speed it up with things like butyrate or looking at methyl donors, because a lot of times it's DNA methylation, which leads to histone protein recruitment to turn a gene off or gene on when it's not acetylation. So 1,000-foot view on that is 2 females can have the exact same total in free testosterone, but have significant effects, both positive and negative, from excess or suboptimal androgen signaling. So history is particularly important, and also just keeping in mind where you are in the cycle and what is your estrogen level relative to androgen, because it is a bit of a tug of rope. Even some females have very high testosterone levels, for example, pregnant females, but they have even higher estrogen levels.
Yeah.
So even if the androgen receptor is activated, it's called it's basically downstream interference or even post-translational interference between the level of the receptor being activated and the gene being transcribed. There is less bang for the buck or less activity of the secondary effects of androgen receptor activation.
Wow, that's complicated, and it's far, we're looking at estrogen, progesterone mainly with females. I mean, this testosterone is huge. Their levels have also dropped. And I mean, it's fascinating how you can just sort of unpack this, Dr. Kyle. And obviously, you're going to make this knowledge more known to more and more practitioners and put this sort of institute out there, because it's fundamentally important, isn't it?
Yeah, absolutely. And by the way, for some ranges, a total testosterone between about 20 and 80 for females is healthy. If they're on HRT with a high SHBG, they can go higher to that. But there's a female, there's a lot of people that say a total testosterone of 120 nanograms per deciliter is normal in a female on HRT. And it might be optimal if the female has an SHBG of 90 and a free testosterone of 1.5 or 2. But in another female, they might have an SHBG of 15 and a free testosterone of 5 or 6.
Okay.
And that is likely not optimal. So both the total and the free testosterone matter for females. And that's actually a similar way to you look at males. I think in previous podcasts, I don't know if I've hurt some feelings, but I noticed commenters saying once he said a total testosterone of 550 can be optimal, nothing else is worth listening to. But in a lot of cases, if you get to a total testosterone of 550, you can have a free testosterone of 30. And that is very likely optimal. You are producing a lot of testosterone, but those individuals tend to have lower SHBGs, even just genetically lower SHBGs. And even if they replaced with TRT with true physiologic replacement, they're not going to have significant health span benefits over that. But yes, to play devil's advocate to that same statement, a total testosterone of 550 and a free testosterone of 4, I have started people on HRT because of levels like that. Often, they may have started with a total testosterone of 300. They get to 500, optimizing everything naturally as possible, but their free testosterone is still significantly deficient. Those are two completely different cases.
Okay. And those people that are over exercising, they're overtraining, either cardio or even in the gym, do they affect their testosterone levels negatively generally?
Mostly when they are deficient in either a nutrient or they're in a significant caloric deficit. If they're between maybe 100 and 200 calories of a deficit per day and over about 10% body fat, testosterone tends not to decrease. Right around 200 calories a day deficit, the intake of fat becomes particularly important. The higher you maintain your fat intake, and this is why a lot of times if a natural bodybuilder is cutting, let's say they need to lose 2 or 3 pounds a week, which is a ton, and they're cutting out mostly carbs, they tend to keep fat very high to maintain decent testosterone output.
Okay, brilliant. Okay, so then we need to go on to, we've done nutrition. Let's just bounce quickly through sleep. How important, you spoke about zone 2 and REM sleep, how important deep sleep and REM sleep with regards to testosterone, levels, measuring these either using Aura. I'm trying circular Aura and Whoop at the same time. I'd actually love your quick perspective. I've seen different levels of REM totally on the opposite side as deep. I'm looking at Whoop, I'm looking at Aura and thinking, my goodness. I know they're not supposed to be accurate, but they're supposed to be precise, making the same errors again and again so you can set a trend. But these 3 different devices are often giving me 3 different values. But tell us about your view, maybe possibly quickly on that, and then also on REM and deep sleep with regards to testosterone.
Yeah, so testosterone is released secondary to LH, and LH is released secondary to something called GnRH. And that doesn't matter to remember, but basically the hormones that are precursors to testosterone are released in a pulsatile manner primarily when you sleep. So basically you produce your testosterone and the signals to start the synthesis of it during sleep. And the better your sleep, the better you will produce. That's why sleep apnea is the second cause of hypogonadism, secondary to metabolic syndrome, just from how common of an occurrence it is statistically. So sleep is of particular importance in regards to tracking your sleep. Whoop, Aura, there's a lot of different ways that are good to track the trends. They are extremely good and accurate for heart rate variability and also for resting heart rate. For things like deep sleep scores and for REM sleep amounts, every time they update their algorithm, it's going to change significantly. Every time they do, they're slowly approaching a better and better algorithm. There are other ways to track it as well. I think there's an 8 sleep platform, which is kind of like a bed. And then there's home sleep studies that are generally much more expensive than whoops or auras, but are reasonable to do, especially if you're concerned for sleep pathology. But they basically just tell you a trend. They're not going to tell you exactly how much REM or deep sleep or the quality of which that you're getting. Dr. Eric Korem, Korem, is an expert in this, and one of the places that I've learned some of the things regarding what is accurate and what's not for biometric data tracking. But they are getting better and better, and I still think it's worth it. But if something's off, I wouldn't worry too much about an extremely low or high amount of deep or REM sleep just from one of those trackers.
Okay. Well, according to the studies in your own experience, obviously REM more in the morning, in the early morning, and deep in the first half of the cycle. I think that's pretty known. But which is more important for testosterone and cognitive function in your view?
For cognitive function, REM is restorative. So usually you have the feeling of being well rested. If you wake up and you remember your dream, then that's kind of normal. You have your deep sleep, you have your REM sleep, and then you have your normal short awake cycle. It's normal to have awake waves, often alpha waves. Deep sleep is delta waves, awake sleep is alpha waves. And usually just during the night, you don't remember these unless you're overly stimulated. So a good sign is you've dreamed, maybe you wake up before your alarm and you feel refreshed and ready to go. That's when you've woken at a good time. Not that you always have to wake up at a good time of your sleep cycle, but that's just one sign. And both are important for testosterone production, both deep sleep and REM sleep. You can have quality of sleep outside it. The quality of your sleep is not only related to your deep sleep amount and your REM sleep amount. So it can also be of varying qualities. If you generally don't remember your dreams, then it could be a sign that your REM sleep is not good. There's been interesting studies on cannabinoids and REM sleep. Sometimes you have actually more total sleep, but less REM sleep, and you tend to not remember your dreams. It's possible that any endocannabinoid receptor agonist, even things like PEA, which is a fatty acid, could do this. But that is one thing to keep in mind. And then conversely, on the other hand, especially things like nicotinic receptor agonist or dopaminergic agents, you think of dopamine and acetylcholine, or just anything that's dopaminergic, nicotinergic, or cholinergic. Cholinergic is basically like a more broad spectrum term for nicotinergic, by the way. Then you could have hyperactive dreams, or if you're in kind of a bit of a hypomanic episode where you have an excess of dopaminergic activity, then your REM sleep can basically have such disturbing or vivid dreams that you wake up in a fight or flight called sympathetic state, and that can negatively affect your sleep. So there is a happy medium or balance that each individual should find. If you tend to be able to lucid dream very easily without a lot of trying it, then it's probably that you have higher baseline dopaminergic activity or possibly cholinergic, nicotinergic activity. And you might want to work on deep sleep or consider something like meditation, mindfulness, or L-theanine. There's a supplement for everything. I'm not totally against supplements.
Good. We'll get into them now. Just one last thing about electromagnetic, non-native electromagnetic radiation, holding your cell phone in your pocket. I know there was some research what it does to testosterone and sperm quality and sperm quantity. What is your view on radiation from cell phones and Wi-Fi's with regards to hormonal health?
Yeah, the dose makes the poison in this case. So obviously we're not living in a particularly natural environment. And I don't think that, never putting your cell phone in a pocket anywhere makes a lot of sense. But I do think that wearing loose fitting clothing, especially around the hips, especially if your glutes tend to be larger, the heat will basically be kept in, and it can add to heat damage. So if you're looking at, I guess, two different phones, if one of them puts out a lot more heat, then that would also be of concern due to its proximity, especially if your venous cooling is impaired. So if you have varicocele or subfertility, or even been known to have lower sperm counts or lower testosterone counts, then that is definitely something to consider. If you're someone that has had no issues with fertility, high sperm counts, high testosterone, then I don't think it's worth changing what you're doing when it comes to laptop or phone placement. But that being said, if you work in a place that's right next to like a huge, I forget what they call it, but they have those huge power plant relays where there's immense amounts of energy being transferred through the lines. That is obviously not a perfectly efficient process. I wish it was. But if you have to be there all the time, then that is potentially quite concerning. I know that my brother is a computer and electrical engineer, and he works on critical infrastructure, which is basically making sure that at least in the United States, basically our electric system is ancient, and a lot of the technology that's used is many decades old and is susceptible to failure and like terrorism and whatnot. But if you have to physically be in those areas for a long period of time, then it does start to be concerning.
Sure. Great. So let's move on to supplementation and talk about Tonkat Ali, talk about Fidocia agrestis, possibly Tribulus terrestris, anything else, boron, anything else you want to really talk about with regards to supplementation, even amino acids. Like I was saying, I started doing the dried blood spot amino analysis. It's been revolutionary for my patients. People smashing in collagen so much and increasing their proline and their glycine. I've seen low lysine at another level. I've seen low arginine. I mean, people that are my typical sort of corporate patients and clients and CEOs, they've got low arginine, low lysine. The females have low valine, isoleucine, and leucine. So possibly speak about supplementation and the amino acid testing you do or you don't do, and what do you think about making sure that the amino acid balance is good?
Yeah, thank you for the question. This is a great opportunity to promote my next podcast, which is the tier list of functional health testing. And perhaps you've discussed this with my friend James before, but we like intracellular and serum micronutrient and amino acid testing. We use a lab called Vibrant, although we're not sponsored by them or anything. We just literally happen to use them because they have a high value test where you get your amino acids, your omega acids, both intracellularly, either in the red blood cell or the white blood cell, and then also in the bloodstream. That way you can tell, maybe you have a low level, or maybe you have a higher level in the bloodstream, but a lower level inside the cell because of amino acid transport. You mentioned glycine and proline. I've talked publicly before about how I have 3 different SNPs. I have genetic glycinuria and prolinuria. So I have a form of proteinuria. Basically, I pee out my glycine and proline. And that's one of the reasons why I'm always having intakes of, I just had a collagen protein in my shake myself. So glycine and proline is great for me because I'm just going to pee out most of it. And that way you attenuate risk of things like osteoporosis when you're low on glycine and proline. But for the average individual, that is not necessarily the case. But anyway, not to rabbit trail too much, we also test coenzyme Q10, glutathione. Cysteine is obviously an amino acid, but you test all those things both inside the cell and outside the cell. Even if you get that test once every couple years or every 5 years, that's an extremely high yield test that both my practitioner colleagues and I use, and our sports dietitian, because you can make actionable advice and very specific dietary advice. In my opinion, it's much more useful than nutrigenomics, because you basically see in vivo your case study of what nutrients are in the blood and what nutrients are in the cells themselves.
Yeah, brilliant. Okay, so that's amino acids, and then you would do compounding based on those amino acids. If you saw something that was really low, then you would ensure that you can, give them some lysine or give them some valine or isoleucine or leucine. What would be your method of intervention?
Yeah, certainly. So if it's a patient that has borderline low growth hormone, then very well, I might use a supplement that has, for example, arginine and glycine in it, and have them take it in the evening, sometimes with a GHRP, like tesamorelin or ipamorelin. And that can significantly improve their endogenous growth hormone production. But occasionally I try to find a more high yield. So for example, if they're low in glycine and proline, like I was, then instead of specifically supplementing with glycine and proline, which is actually pretty rare, then I just take more collagen protein because it happens to have a good profile of that. If someone is higher in methionine and lysine, or their methionine homocysteine cycle is getting backed up, in addition to giving them, like lots of methyl donors or creatine or betaine, then perhaps I have them dial back their methionine content in the diet a bit, as long as it doesn't affect their quality of life too much.
Brilliant. Okay, talk about Tonkat Ali and Fidocia agrestis and Tribulus terrestris, any of these, or boron, specifically used to optimize testosterone in the male and female.
So with these, I think about rate limiting step. So if it's steroidogenesis, especially an individual with low insulin and low IGF-1 growth hormone, those happen to help upregulate basically those same synthetic steps that Tonkat does. We used to think that Tonkat was an aromatase inhibitor, but it actually increases estradiol proportionally to testosterone. And anecdotally, I've seen it work quite well when LH and FSH are relatively high. And it just seems like steroidogenesis is not optimal, especially if an individual is in a caloric deficit. Tonkat's also a phytoandrogen, like Tribulus likely is, where Tribulus does not significantly increase testosterone, but it likely does bind the androgen receptor, just like soy or other isoflavonoids. There's a lot of other things that are phytoestrogens. Hops is a phytoestrogen. And in general, low amounts of phytoestrogens is great for health, as long as it doesn't cause symptoms of too much estrogen. So individuals like myself, again, not to make myself the example for everything, everybody's unique. My estrogen tends to run very low, which is actually concerning for my cardiovascular health. And I like hop water, which is basically just water, and they put hops in it because it smells good, and it kind of tastes good too. And it comes in a can, and you kind of feel a lot of the benefits of drinking an alcoholic beverage, where it's not that way. And it's also way less nasty than non-alcoholic beer. So I think it's a win-win for me, even though I'm drinking hops, which can be quite estrogenic. But for some individuals, that would put them over the edge, and they get sensitive nipples and all sorts of other side effects, moodiness.
Is that why drinking beer can cause your estrogen to really increase? And rather changing from beer to whiskey, you see people with gynecomastia and really struggling with maybe a bit more estrogen dominance, and they should limit taking alcohol in the form of beer.
That's one of the reasons. The other reason is that beer tends to have a lot of calories, and it spikes your insulin. So the higher your insulin, the more bang for the buck you'll get at the androgen receptor, and also estrogen receptor, because your SHBG is going to decrease. So both your free androgens and free estrogens will increase. And it's not necessarily an effect that's unique to beer, but most liquid calories will do it. So if you take whiskey, and then most mixed drinks with whiskey don't have a ton of sugar, but if you take something, I can't even think of an example, maybe a margarita, I think that has a lot of sugar in it. But if you take the equal amount of sugar and calories in that drink, that's probably going to cause similar symptoms. But that being said, hops does have a bit of an effect, especially at very high levels. So if you drink half a dozen beers, then you're definitely going to feel that effect. So that's Tonkat. Fidocia is very interesting because although there is not great, there's really not great literature, but there's great anecdotal evidence. And that's how things like aspirin started out, anecdotal evidence of taking willow bark extract and whatnot. That's how Tonkat started out as well. That's actually how rhodiola is. We have no idea what the mechanism of action of rhodiola rosea is, but we know that it works. So we just call it an adaptogen. And I actually like that for some individuals, but I'm also a fan of mechanism of action. And I've seen enough LH levels go from low or normal to very high on Fidocia. And I've seen people's testosterone react to that if you tend to have a lower LH level, then that can be something very reasonable to utilize, especially given its likely good toxicity protocol. So things like SERMs, people always ask me, why would you use Fidocia when you can just use enclomiphene or Clomid? And I don't hate enclomiphene or Clomid. I like enclomiphene specifically for fertility for short periods of time. But it is going to significantly increase your risk of blood clots and strokes. And Fidocia is very, very unlikely to do that. So just for those reasons, I would personally rather take it than clomiphene or Clomid if it was for a couple years and you're checking your labs to make sure you don't have more oxidative stress.
Brilliant.
So another one we can mention is Sensoril ashwagandha. Sensoril or KSM-66 are probably the two best forms of ashwagandha for tolerability for individuals with high cortisol in the evening. So cortisol can also impair testosterone release. So if that's your rate limiting step, you can remove that barrier with a bit of ashwagandha. Some people also use phosphatidylserine. So that's also reasonable, especially if you have poor REM sleep, phosphatidylserine. The next one is vitamin D, zinc, magnesium, boron. They all kind of go hand in hand. If you're not getting optimal levels of them in the diet, then they can be particularly useful, not just for androgen synthesis, but also for thyroid health.
Okay, brilliant. Anything else?
I think that's a pretty good summary of high yield supplements. We mentioned creatine earlier. Creatine's great in almost all situations. So slightly raised testosterone, slightly raised DHT. It's especially useful for people with higher homocysteine levels.
Sure. And there's a lot of research coming out about creatine. When I first looked at it like 15 years ago, it caused kidney damage, and there was a lot of things in terms of what it does to your GFR. And so has that all been sort of now disproven? It's a pretty healthy, extremely well-researched supplement.
Yes, it will make it does have the potential to make your creatinine levels look higher, especially if you're on medications for HIV. Actually, there's several case studies of creatinines of 5 or 6, and they send the person to the hospital to get dialysis. They're in kidney failure. They check a cystatin C, it's completely normal. And it just turns out they're on creatine. So depending on the medications, some of them it does interact, but as long as you check a cystatin C, then you don't have anything to worry about. And if people want a summary of all my different lab panels, they can just go to my website, GilletteHealth.com, and regardless of where you order them from, even if you take them to your regular doc, you can screenshot them or print them off and find those biomarkers.
Wow, that's very helpful. Thank you so much. Now let's go on to TRT. Tell us about the risks. You know, there was a lot of indication about risk to prostate health, and then looking at causing emboli, pulmonary embolism, and looking at venous embolism. What is your view now on TRT with regards to safety and risk?
Yeah, so TRT, I would say with the last study that came out, it's not like one study makes a huge difference, but there was a big study out of the New England Journal of Medicine. And I believe in a week, our podcast on that comes out. We filmed it last week. So it's almost done editing. And we posted about it on Instagram as well. But yeah, it looks at the risks, the cardiovascular risks or the heart risks of TRT. And they chose an extremely high risk population. So they had a lot of balls to choose that group. So I was very thankful for that. But basically, it did not increase the incidence of heart attack or stroke. It slightly decreased the incidence of diabetes. They studied them for just 3 years. So it's hard to make a huge difference in that. But it did have a slight clinically significant effect. And there was slightly more blood clots and also slightly more incidences of AFib or arrhythmias. And I guess the caveat to that is the blood pressure slightly increased, and we don't know what antihypertensive therapy they used. So for individuals on TRT that are also high risk, if they're not a high risk group, then they likely still have some of these same risks, but they're just not going to happen near as often. For example, I think 1 in 100 got a blood clot in the lung, potentially life-threatening condition that was in this very high group. High risk group, and 1 in 200 got a blood clot that was in the placebo group. But they didn't screen them for things like factor V Leiden, which is a pretty common cause of a hypercoagulable predisposition. Basically, your blood will clot easier. And there's other things like prothrombin, antithrombin 3, lupus anticoagulant, antiphospholipid antibody syndrome, high platelet counts secondary to estrogen. So the higher your estrogen goes, you need to check your platelets to make sure they don't go far. And then thromboxane, which is basically the stickiness of your platelet, which even endogenous testosterone will dysregulate. So you have to take into account all of these factors. That's why I say if you're a hormone expert, you can't just know how to dial in hormones. There's lots of health coaches, or actually there's just lots of people that are interested in health optimization, and they could likely, if they were allowed to go get over-the-counter testosterone, they could get labs on my website without, they could just go get them themselves, no oversight whatsoever. And they could bring themselves to a total testosterone of 900 and a free testosterone of 25 pretty easily. But you have to be well-versed in all organ systems. So depending on the person, rather than just, instead of ordering those tests for every single individual, choose the ones that are at moderate or high risk. And then for those at low risk, you still mention them, but say, regardless of this, then it's not going to significantly change our management. Okay. That's why it's important to get, actual health advice rather than self-prescribing your TRT.
But overall, pretty safe if guided by it's another level of depth here of hormonal health and organ systems, but generally well tolerated. But once you start TRT, is that it? You got to be on for good. Once you start that process, does someone then have to just sort of budget long term with regards to TRT?
The way I describe it is it's a indefinite commitment. I used to say lifetime commitment. If you come off, then there's a 99.8% chance that you can regain all of your previous function. If you come off cold turkey, you're going to feel terrible when you come off. So I don't recommend that anybody does that. But there are many good ways to get people off TRT. And I've helped probably hundreds of people at this point get off TRT for various different reasons. But most that come off just weren't ready to come on, or they weren't thinking about, there was an unforeseen side effect, often fertility. That being said, some of the best sperm counts that I've ever seen are men on TRT, often with HCG, FSH, L-carnitine, et cetera, gonadorelin sometimes, but still, it's most people that go on TRT can come off. That's why it's very important to know your pre-TRT LH, FSH, and total and free testosterone, and ideally prolactin and estradiol as well, because that way you can know what to expect that you can get back to.
Okay. And that's male. And obviously female. Are you supplementing TRT a lot with a lot of females now? Is it in the cream form? Is it the injectable form? Are they needing as much TRT as the male?
I'd say about 50% of the times, especially females with low DHEA sulfate, I supplement with TRT over supplementing with DHEA sulfate, because often it just converts to estradiol even more often. And a lot of times they're already on a low dose of estradiol. Some females, especially with very low testosterone, before menopause or right around the time of menopause, I supplement with just testosterone and progesterone, because they're still producing estradiol, but their progesterone levels have significantly decreased to where they're having symptoms, and also their androgen levels have decreased to where they're noticing body composition and metabolic changes. Lately, especially for females that no longer desire fertility, I've really liked oral lymphatically absorbed testosterone, undecanoate, with dutasteride. It's extremely female friendly, partly because you can take it just in the morning, partly because you can take dutasteride with it and prevent androgenic side effects. Lymphatically absorbed, and also cream converts to DHT more often. So great for females that are less sensitive to androgens. Females that are more sensitive to androgens, almost paradoxically, injectable testosterone is often a better form. So a lot of times if a female has an average SHBG, quite sensitive to androgens, I'll use something just like 3 mg a week of injectable testosterone cypionate, and it won't budge their SHBG that much, and it'll be just enough to get them the metabolic benefit and also convert to estradiol a bit.
Okay, good. Last question. It just seems with all these issues in our environment, xenoestrogens and dysregulation of hormones, it looks like almost everyone has to then, supplement with, testosterone or, the estrogens. I don't want to get into HRT or anything like that and different forms of it, but it just seems if you're living in a modern day city, someone's listening out there, they're most likely going to need some type of exogenous hormonal input.
Yeah, especially if your goal is a long health span. So earlier you mentioned if something can be done safely for a long run, and if you're going to be decreasing your lifespan because of HRT, and if it's adequately managed, then you're not. But you could make the case that, especially for females, or men who go through andropause early. There is no way that you will have the same amount of health span. Think about your grandparents, your great-grandparents, when the quality of their life really started to decrease. And without HRT for many individuals, especially females, expecting a health span of 100, 110, 120, there's just no way that is possible without hormone replacement.
Brilliant. Anything else you want to mention, Dr. Kyle? It's been another level of complexity. You're going to have to dissect this and distill it and deconstruct it for people, but very grateful. Anything else you want to sort of send out there as a message of hope with regards to hormonal health?
Yeah, one thing that I like to sum up, I guess, is what I call the Punnett square of health optimization. So you have an x-axis and a y-axis. And on the x-axis is whether or not you see yourself as healthy. So you can see yourself as healthy, or you can see yourself as sick. And on the y-axis is, what are you doing? Are you doing something to improve your health? And often, especially for males, not to specifically call out them, but they hate going to the doctor. They hate going to health coaches. They hate doing anything for quality of life because they see themselves as healthy, even if they're not. And then they move themselves into this sick category. I call that the sick role. What you want to do is you obviously want to do things to improve your health and prolong your health span, but also see yourself as healthy. And often it's difficult to get in both of those boxes at the same time. So as people go through their health journey and they seek out high quality health advice, even if you feel terrible, and I kind of felt the same way when I started supplementing as well, when I went into my 30s, you might be taking half a dozen or even 10 different pills every single day. But remember, that's in order to optimize your health. That's not because you're unhealthy. You can still see yourself as that person with good health. And that in and of itself is a self-fulfilling prophecy. It's a positive mindset that will bring you better health in the future.
Brilliant. Well, I want to just declare favor and blessing over you, that you would just rise up with courage in your calling. I know that you're going to speak to not thousands, but millions. And yeah, you've been just wonderful to listen to. And we'll put links to your podcast and to your website, and there's different ranges, and people can sort of print those out. So I think I always end off with doctor, the Latin docere, to teach, and I think we've all got a responsibility to teach and empower people, not to make them doctors, but for them to take personal accountability of their health. And so thank you so much. And if you're ever in South Africa, you've got a home here, I would love to have you out. I know you've got 2 kids, and yeah, we try and host as many of my guests as possible in the network that we build all over the world. So from our, really deep thank you and we're going to promote this podcast as much as we can. We'll put on YouTube, and I think Africa needs to hear more of your voice, Dr. Kyle Gillett.
Thank you. My pleasure.